Welcome to the Deep Dive. We're here to take complex topics and, well, make them stick fast.
That's the plan.
Today we're tackling something really central in clinical practice. Diuretic drugs. Essential stuff.
Absolutely essential. Our mission today is basically to give you the core pharmacology of diuretics, the drugs at the heart of managing hypertension and heart failure. It all comes down to understanding the kidney.
Okay, so let's start with the basics. What exactly is a diuretic?
Simply put, they're drugs that speed up urine formation. The main way they do this is by getting rid of sodium and water from the body.
And the origin story is kind of wild, isn't it? Just stumbled upon.
It really is. Came from a mercury-based antibiotic, completely by accident. Obviously, we don't use those anymore. But the main classes we rely on now developed pretty quickly between the 1950s and 70s.
And they're still everywhere.
Oh yeah, among the most prescribed drugs globally. They're effective, generally low cost.
Which makes them first line for things like high blood pressure, especially thiazides, and almost indispensable for heart failure patients. But there's always a trade-off, right?
Yeah.
What's the main watch-out?
The biggest risk really comes from them working too well. You get metabolic side effects because of excessive fluid and electrolyte loss. Mostly, it's about potassium levels going haywire.
But that's usually tied to the dose.
Exactly. Dose-related. So careful management, careful titration, that's key to keeping things safe.
All right, so we've got 5 main types to get through today based on where they jump into the kidney's fluid handling system.
That's right. We have Carbonic Anhydrase Inhibitors, or CAIs, loop diuretics, osmotic diuretics, Potassium-Sparing diuretics, and the thiazides and their cousins, the thiazides likes.
And you said understanding where they work is everything. So we need a quick kidney map.
Let's zoom in on the nephron. That's the kidney's functional unit, about 1 million per kidney. Forget the initial filter, the glomerulus, for now. The real action for diuretics is in the reabsorption part.
Stopping sodium and water from getting pulled back into the body.
Precisely. Where does most of that happen?
Where's stop number 1?
Okay, first big stop. The proximal convoluted tubule. This section is the powerhouse. It pulls back something like 60 to 70% of all the sodium and water that just got filtered.
60 to 70%. Okay, that's massive. Where's the next big chunk reclaimed?
That happens in the thick ascending limb of the loop of Henle. It grabs another 20 to 25% of the sodium.
Right.
Then finally, the last 5 to 10% of sodium gets reabsorbed downstream in the distal convoluted tubule, and that last bit is really tightly controlled by the hormone aldosterone.
So the drug's power, its potency, depends on where it hits along this pathway.
Exactly right. How potent a diuretic is depends on how much of that sodium and water reabsorption it blocks. And generally, the earlier it acts in the nephron, the bigger the effect, because it's dealing with more concentrated filtrate.
Okay, that makes sense.
Yeah.
Which leads us nicely to the real powerhouses of the group, the loop diuretics.
The loops, yeah. Furosemide, brand name Lasix is the classic example. These are definitely the most potent. They work right on that thick ascending limb of the loop of Henle,
Where that second big chunk of sodium gets pulled back.
Yep, and they aggressively block chloride reabsorption, which then stops sodium from following.
So that's why they're go-to drugs for acute situations like sudden fluid overload in the lungs, flash pulmonary edema.
Exactly. They cause this really powerful, rapid diuresis. It quickly lowers preload, takes the pressure off the heart and veins. They even help dilate blood vessels by activating prostaglandins in the kidney.
But here's the key clinical point, isn't it? The thing everyone needs to remember.
This is critical. Loop diuretics keep working even when kidney function is really poor. Like when the creatinine clearance dips below 25 millimin.
That's the aha moment, right? If the kidneys are failing significantly, furosemide is often the only one that's still going to be effective. That GFR number, 25 LMN, is vital.
It absolutely defines their utility in severe kidney disease, but that power comes with significant risks. The main one is serious hypokalemia, low potassium. Patients often need potassium supplements.
Okay.
And there's also a potential, though less common, risk of ototoxicity, hearing loss, usually linked to high doses given intravenously.
And what about drug interactions? You mentioned combining loops with certain antibiotics, aminoglycosides or vancomycin. Sounds risky.
It is. Big red flag there. Both the loops and those antibiotics can potentially harm the kidneys and nerves. So putting them together, you get an additive risk, maybe even synergistic. It's a dangerous combo. Also, something patients need to know. Common painkillers, NSAIDs like ibuprofen, can actually reduce how well the diuretic works. That catches people out sometimes.
Okay, so loops are the big guns for systemic fluid overload. But what if the problem is more localized, say, swelling inside the skull from a head injury? You wouldn't use a loop for that, would you?
No, that's a totally different scenario, and that's where our second high-power class comes in, the osmotic
Like
diuretics.
mannitol.
Exactly. Mannitol is the main one. It works in a completely different way. It's basically a sugar that the body can't reabsorb easily.
So it stays in the kidney tubule.
Right. It acts mainly in the proximal tubule, but really all along the nephron. Because it's stuck in the filtrate, it increases the osmotic pressure, essentially pulling water out of surrounding tissues like the brain and into the tubule to be peed out.
So it forces water out, but the key thing is it doesn't mess with electrolytes much.
Correct. You don't really use it for typical swelling, like in the legs. Mannitol's main job is critical care stuff. Reducing high pressure inside the head, like from cerebral edema after trauma, or helping protect the kidneys during acute injury.
And there's a specific way it has to be given, right? 5E only, with a filter.
Yes, that's crucial. Mannitol can crystallize, especially if it gets cold or is too concentrated. Infusing crystals would be disastrous, so it must go through a filter during IV administration.
Okay, moving on. Let's step down the potency ladder a bit to the everyday workhorses, especially for high blood pressure. The thiazides.
Yes. Thiazides and the thiazide-likes. Think hydrochlorothiazide, or HCTZ. These are probably the most commonly prescribed. They act a bit further down in the distal convoluted tubule.
Okay.
There, they inhibit the reabsorption of sodium, potassium, and chloride. But they also have this neat secondary effect. They directly relax the smooth muscle in arterioles.
So they lower peripheral vascular resistance too. Double benefit for hypertension.
Exactly. But unlike the loops, their effectiveness really tanks if kidney function declines.
Right. This is their Achilles heel. What's the cutoff?
Generally, their efficacy drops off significantly if the creatinine clearance falls below about 30 to 50 millimilli.
So for most patients with moderate to severe kidney disease, thiazides aren't the best choice.
Correct. Although there's one interesting exception, metalozone. It's thiazide-like, but somehow it keeps working even when clearance is down to 10 millimilli. So you see it used sometimes in really tough heart failure cases, often combined with a loop.
Let's talk side effects and dosing. We know they waste potassium, like loops, but they also have these metabolic issues, right? Blood sugar and uric acid.
Yes, that's important. Besides hypokalemia, thiazides can cause hyperglycemia, raise blood sugar, and hyperuricemia, raise uric acid levels, which could trigger gout.
And these are dose dependent.
Definitely. There's a ceiling effect for HCTZ around 50 milligrams, meaning higher doses don't really give much more diuretic effect, but do increase the metabolic risks. That's why, for hypertension, the usual advice is to keep the HCTZ dose at or below 25 milligrams daily.
That 25 milligram guideline is crucial, especially for patients with diabetes, right? You need to be extra careful.
Absolutely. Thiazides can work against some oral diabetes medications, so blood sugar needs closer monitoring. And just like with loops, the low potassium they cause increases the risk of toxicity if the patient is also taking digoxin.
Okay, let's quickly touch on the least potent class. Carbonic Anhydrase Inhibitors, CAIs, acetazolamide is the example here. They work way up in the proximal tubule.
Right at the beginning, CAIs block the enzyme carbonic anhydrase. This enzyme is needed to make hydrogen ions, which the tubule exchanges for sodium. So blocking it indirectly reduces sodium reabsorption.
But they're not really used much for typical diuresis.
Not primarily. Their diuretic effect actually fades after a few days because they cause a metabolic acidosis, which sort of puts the brakes on their own action.
So what are they used for? Seems like niche uses.
They are. Primarily for glaucoma, they reduce the production of fluid inside the eye. And they're also quite effective for preventing or treating symptoms of high-altitude sickness, sometimes used as add-ons for resistant edema, but briefly.
Got it. Okay, final class. The potassium-sparing diuretics. The name kind of gives it away.
It does. Their main job often is to counteract the potassium loss from thiazides or loops. They work late in the game in the collecting ducts and the very end of the distal tubules.
And there are two main ways they work.
Yes. First, you have spironolactone. It directly blocks the action of aldosterone. Aldosterone normally tells the kidneys to hold onto sodium and water and dump potassium. Spironolactone reverses that you lose sodium and water, but keep potassium.
And the other type, amiloride and triamterene.
Right. They don't mess with aldosterone. They work directly on the channels in that part of the tubule to block sodium reabsorption, which indirectly reduces potassium excretion.
So on their own, they're not super strong diuretics.
Relatively weak, yes. Their main value is usually being combined with a thiazide. You get a boosted diuretic effect overall, plus the potassium-sparing drug helps prevent the thiazide from causing hypokalemia. It's a smart combo.
And spironolactone has that extra benefit, particularly in heart failure, beyond just fluid removal.
It does, and it's a big deal. By blocking aldosterone, spironolactone helps prevent harmful changes or remodeling in the heart muscle itself. This is really important for improving outcomes, reducing mortality in patients with severe heart failure. It's genuinely cardioprotective.
But if they spare potassium, the big danger must be the opposite problem. Too much potassium, hyperkalemia.
That is the absolute critical risk here. Getting serum potassium above 5.5 millimolo is dangerous, and you have to be incredibly careful combining these potassium-sparing drugs with things like ACE inhibitors or ARDs, which also tend to raise potassium.
Or potassium supplements, obviously.
Absolutely. That combination can quickly lead to life-threatening heart rhythm problems. Serious stuff.
Which brings us neatly to the nursing process and safety across the board. What are the key assessment points before starting any diuretic?
Well, you need that baseline. Listening to breath sounds, heart sounds, checking for edema, skin turgor, assessing fluid status, and tracking daily weights and intake output is fundamental.
And you mentioned orthostatic hypotension earlier. Measuring postural blood pressure seems non-negotiable.
Totally non-negotiable. Check BP lying down, then sitting, then standing. Wait a minute or two between positions. If the systolic pressure drops by 20 points or more when they stand up, that's orthostatic hypotension. That patient is a high fall risk, especially older adults.
And labs. What are the must monitors?
Kidney function, so BUN and creatinine. And then the electrolytes. Definitely potassium, sodium chloride, magnesium and calcium are important too, and uric acid, especially with thiazides.
Okay, patient education. Let's talk timing. Why is morning dosing so important?
Simple, practicality, and safety. You want the peak diuretic effect to happen during the day, not overnight. Taking it late means the patient will be up all night needing the bathroom nocturia. That disrupts sleep and, crucially, increases the risk of falls when they're getting up in the dark. So, morning dose is standard.
And the dietary advice around potassium, this seems like the area most likely to cause confusion.
It really can be confusing. So the rule is, if you're taking a loop diuretic or a thiazide diuretic, the ones that waste potassium, you generally need to increase potassium in your diet. Think bananas, oranges, potatoes, tomatoes, fish, leafy greens. But if you're taking a potassium-sparing diuretic like spironolactone, amiloride, or triamterene, you need to do the opposite. You must avoid potassium-rich foods and definitely avoid salt substitutes that contain potassium chloride and potassium supplements.
The risk is hyperkalemia.
Exactly. Life-threatening hyperkalemia.
And patients need to know the warning signs of imbalance either way, right?
For sure. For hypokalemia, low potassium, which is the risk with loops and thiazides, watch for things like feeling unusually tired or lethargic, muscle weakness or cramps, confusion, maybe even irregular heartbeat.
And for hyperkalemia, high potassium, the risk despairs.
That often presents with nausea, vomiting, maybe diarrhea, abdominal cramping, any of those. They need to report it right away.
And one more reminder for patients with diabetes.
Yes, if you have diabetes and you're starting or changing the dose of a thiazide or a loop diuretic, keep a closer eye on your blood glucose levels because they can potentially increase them.
Excellent. That covers a lot of ground. Let's try a quick recap, tying the drug class back to the site of action in the nephron, proximal tubule.
That's the CAIs and the osmotic diuretics.
Okay, the powerhouse section, the loop of Henle.
That's where the loop diuretics work their magic. High potency, still work in kidney failure.
And then the later sections, distal tubule and collecting ducts.
That's thiazides and the potassium-sparing diuretics.
Perfect. So, wrapping this all up, what's the big clinical takeaway, the provocative thought to leave our listeners with?
I think it comes back to that risk-benefit balance, especially with combinations. We talked about how spironolactone plus an ACE inhibitor can be life-saving in heart failure by tackling fluid and remodeling.
Right.
But that exact same combination creates one of the highest risks for deadly hyperkalemia. So the takeaway is, powerful therapies often have powerful risks right alongside them. Continuous, vigilant monitoring, especially of potassium in that scenario, isn't just recommended, it's absolutely non-negotiable.
A really critical point of synthesis. Thank you so much for walking us through all of that. It's been incredibly helpful.
My pleasure. Glad to do it.
And thank you, our listeners, for joining us for this deep dive. We hope this rapid review helps you in your studies and your practice.